بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك العليم الحكيم. My topic today is about liver lesion with capsule or halo on MRI. Key for the differential diagnosis: most benign hepatic masses don't have capsule or circumferential rim evident on MRI or CT. Most cysts, cavernous hemangiomas, focal nodular hyperplasia. What is halo? Halo is edema or compressed liver tissue surrounding a lesion. What are the differential diagnoses? The common causes of include hepatic metastases, hepatic pyogenic abscess, hepatocellular carcinoma, and hepatic hematoma. What are the clues for the common diagnosis? Hepatic metastases, most common etiology for lesions with circumferential rim on MRI or CT scan, often have peritumoral halo with double ring pattern. Metastases are usually heterogeneous, hyperintense in T2 weighted images. As we see here in axial T2 weighted MRI image, we have multiple liver metastases, and this one has halo, peritumoral halo, and these are metastases from the colon. Another patient with hepatic metastasis shows multiple hepatic metastases from the colon with peritumoral capsule or halo. Hepatic pyogenic abscess, usually multiloculated or a cluster of a Graves appearance. Abscess contents are hyperintense with thick perilesional edema, also bright in T2. As we see here, pyogenic abscess, MRI shows multi-septated mass or a cluster of adjacent masses, as we see here in the involving most of the right lobe, segment 5-6, with contrast enhancement of the septi and surrounded by inflamed liver. And hepatic abscess, non-enhanced T1 weighted images shows encapsulated multiloculated abscess with heterogeneous fluid content with hyperintense on T2 weighted images, but not shown in this context here, and the component of hypertense on T1 as we see here. An unusual feature usually indicated a proteinaceous material or hemorrhagic fluid. Hepatocellular carcinoma in patients with cirrhosis or chronic liver disease, a presence of capsule in hypervascular mass with washout is diagnostic of hypercellular carcinoma in this setting. Look for signs of cirrhosis, ascites, portal vein invasion. As we see here, hepatocellular carcinoma in this 56-year-old man with heterogeneous hypervascularity on the arterial face, and it is seen on segment 2. And here, this is the same patient with hepatocellular carcinoma, and this is delayed scan, and this is the washout, and this is characteristic of hepatocellular carcinoma. And you see the capsule surrounding the lesion. Here, this is another patient with hepatocellular carcinoma, hypervascular on arterial face, T1 weighted images. And this is the hepatocellular carcinoma of the same patient with washout on delayed face, and you see the capsule on the delayed face. It is still enhancing, and the center of the mass, it is washout in patient with the chronic liver disease. Hepatic hematoma following blunt or penetrating trauma and including iatrogenic injuries. Chronic hematomas may have hemosiderin in REM that is hypointense in T1 and often hyperintense in T2 weighted images. As we see here in this patient, we have subhepatic hematoma with the patient post-transplant and encapsulated hepatic lesion bright on T2 weighted images typical of subacute hematoma. And we see here also the artifact due to metallic cliffs and cords. This is the same patient with perihepatic hematoma following liver transplant, and we see hyperintense REM or capsule on T2 weighted images. In T1 weighted images. Less common causes include hepatic adenoma, hepatic amebic abscess, hepatic hydatid cyst, focal nodular hyperplasia, nodular regenerating hyperplasia, nodular regenerative hyperplasia. Clues for the less common causes: hepatic adenoma may have thin, usually incomplete capsule that is hypointense in T2 weighted images. Look for evidence of hemorrhage, fat, necrosis within the mass. Much more evident on MRI than on CT scan. MRI may show lipid content by signal loss on fat suppressed or opposed phase gradient echo sequences. We see here arterial CT scan, arterial phase CT scan image. In this woman, 25 years old, has a mass here with hypodense comparing to the liver tissue, likely due to lipid, and here we see the capsule, incomplete capsule surrounding the lesion. And this is again the same patient with hepatic mass is encapsulated, as we see here. It is enhancing and the hypodensity of the mass is indicative lipid content, indicating lipid content of this hepatic adenoma. Here another patient with hepatic adenoma, young woman with hepatic mass here, and this is the capsule hypointense and encapsulated the mass is slightly hyperintense to the background of the liver in this in-phase gradient echo. And this is the out-phase gradient echo. The mass become hypointense in nature, indicating the lipid content of the hepatic adenoma. Hepatic amebic abscess, usually one or few lesions seen in the liver, contents bright on T2 weighted images, hypointense rim but periregional edema bright in T2 weighted images, rarely have multiseptated appearance as in pyogenic abscesses. As we see here in this CT scan, enhanced CT scan hepatic amebic abscess in young man with solitary mass lesion with shaggy appearance of the wall and or capsule. And you see also the hyperemic area noted around the lesion. And we see here the anterior segment of the right portal vein. It is occluded, and we see in this patient. Hepatic Hydatid cyst, REM cyst, is hypointense in T2 weighted images. Content daughter cysts are very bright in T2. Here, hepatic hydatid cyst, coronal T2 weighted image shows encapsulated large cystic mass with numerous septi within the mass representing scoliosis or daughter cyst within the large endocyst. This is the coronal T2 weighted images with hepatic mass with internal septi and daughter cyst, and the capsule is bright on T2 weighted images of this hydatid cyst. Focal nodular hyperplasia may have pseudocapsule of a prominent draining vein, no surrounding edema or invasive feature seen. As we see here in this CT scan image, contrast arterial phase, large mass, enhancing mass, abdominal mass with central nadus scar, and we have dilated veins on the surface of the mass simulate a capsule, as we see here, and this is another patient with focal nodular hyperplasia, and this is delayed phase echo. Vest enhanced MRI shows an exophytic mass lesion that retains more contrast, and it is brighter than the background of the liver. As we see also the central scar and the pseudocapsule of the dilated draining vein in this area. And this is the pseudocapsule, it is not enhancing. Nodular regenerative hyperplasia seen in body-carry hypervascular nodule plus minus hypointense halo. Large regenerative nodules, macroscopic, multi-acinar from nodular regenerative hyperplasia. As we see here, nodular regenerative hyperplasia in young man with body carry syndrome, venous phase, we see multiple enhancing nodule hypervascular, and large amount of ascites. Some of nodules are encapsulated and others have central scarf. In this clinical setting, the findings are characteristic of a macroscopic form of nodular regenerative hyperplasia. Here another patient with nodular regenerative hyperplasia. Axial T1 weighted image shows hypervascular masses in body carry. Some of these lesions are have hyper-intense halo and central scar. As we see here, hypointense halo and central scarf. Here hypointense halo, here it is central scarf, and this is typical of multi-acinar nodular regenerative hyperplasia. Thank you for listening. Hoping to see you soon in another talk.